An interesting session today. Vitreoretinal surgeries for ocular surgery complications by APVRS. And I have with me on the dais Dr. Andrew Chang and Timothy Lay. And I'm sure we look forward to a very interesting session this afternoon. Please feel free to have interaction at the end. And I'm happy to invite our first speaker, Dr. Sangeet Mittal, who would be speaking to us on managing dark side of clear vision, RD after cataract surgery. Dr. Sangeet is a very senior vitreoretina consultant from Thindai Hospital, Jalandhar.
Thank you. Good afternoon, everyone. So I'll be speaking on the darker side of clear vision, which is retinal detachment after complicated cataract surgery. Can I have, yeah, thank you. So in my talk, this is stuck. So in my talk, all the things that I'm going to present are, you can say, imaginary and fictional, and the views expressed are mine only, and they're not meant to hurt anybody. And the goal is to have a happy and a satisfied patient. So cataract surgery and retinal detachment, the risk of RD increases after cataract surgery, which is 1%, which is more in intracapsular procedures, and if the capsular integrity is lost, more if there is loss of vitreous loss is there, it increases to 8%. And especially in high-risk cases like myopia or symptomatic patients, it is even more. And it is also seen after YAG capsulotomy we do for posterior capsular opacification. The management of retinal detachment starts even before the cataract surgery starts. And we have to prevent actually not to reach that stage. And a meticulous fundus examination before the patient is taken up for cataract surgery is mandatory. And if there is any high risk, if there are any lesions, especially in high risk cases, they need to be treated properly by either by laser or by cryo. And then there are several intraoperative steps that every cataract surgeon should take while operating, because we have, the first thing is to maintain the visualization. Because poor visualization of retina is key, proper visualization is key to diagnosis and management of many retinal diseases post-operatively. And if you have something like this, it is almost impossible to see the retina post-operatively. So we have to take care that we don't land up in these situations. We have to preserve the corneal endothelium. We have to suture if the corneal incision is large. And we have to make an adequately sized anterior capsulotomy. Proper cleaning of capsular bag has to be done. And the lenses that we use should be compatible with the retinal surgeries. And we have to take steps to minimize the happening of PCO by proper cleaning of the capsular bag and by using square edge IOLs. And another thing is that is important is we should choose compatible IOLs. So what happens is, like in this video you see there was a silicone IOL which was used. And when we use silicone oil in these type of patients, it commonly sticks to the posterior surface of the lens. And then it is very difficult to remove it properly, and the optics is compromised. And again, you see in this type of lenses, which are the iris supported lenses, during a simple FGE procedure, the lens tilted and stood up, and it was difficult to do the surgery. But just by proper use of viscoelastic, we were able to maintain the lens in position. And now you see that the lens is stable even after doing a fluid air exchange. So these things have to be kept in mind when we choose the IOLs. And again, the IOLs with the, and then another thing is, like, if you have a PCR, you should properly manage it. You should recognize it early. Just don't ignore it. You can recognize it by when there is an increase in AC depth, there's loss of rotation, or there is a resistance to phaco. And you don't, what happens is, don't pull out of the eye immediately. When you see that there is a posterior capsular rent happening, just stay there, inject some viscoelastic from the side port, and then remove the main phaco handpiece out. Do a proper vitrectomy and put a proper IOL either in the bag or in the sulcus, whichever, depends upon the capsular integrity, what is there. Next step is to manage the lens fragments which have gone below. So posterior chamber nucleus fragments must be raised into the anterior chamber. But if the lens fragment has crossed below the posterior capsule and has descended into the posterior segment, they should be left in place for later removal with a full 3-port pars plana vitrectomy later on. And the one message that I would like to give is just don't fish. Just focus on safe management of the anterior vitreous. Consider lens implantation if you could. Manage the wound and don't fish. And you see what happens if you fish. In this one particular patient, the nucleus has fallen. The surgeon tried to fish, and he created a large break right in the center of the macula, leading the patient to bad vision for lifetime. So in this patient, again, we had removed the nucleus. We used a phacophragmatome. We did vitrectomy. We put in oil. So oil was necessary because the break, we had to laser the break post-operatively, immediate post-operative period, and then we closed the case. Remember, lens material itself cannot damage the retina unless it is manipulated by a surgeon, and attempts to raise a drop nucleus into anterior chamber for removal creates unsafe vitreoretinal traction. Now coming to the last part, that is proper management. The first thing we have to do is we have to take care is optimize the cataract surgery. If I ask any retinal surgeon in the world, he will say the most difficult cases to treat are the ones with badly managed cataract surgery. And you see the various problems we face. There is a lot of hypotony. There's difficulty in insertion of the infusion cannula. And once, even if you get the insertion, it goes into the suprachoroidal space. You have to make sure that the cannula now is in the vitreous cavity, and then only you have to start the infusion. And here you see when we started the infusion, the incision was leaking. There was vitreous still in the wound. And we have to take care of this, remove the vitreous, remove the remaining lens matter, put in an lens, and then we have to push further for the vitreous surgery. And another case, you see the lens that has been used is totally improper, not for the size of the eye that is being used. The lens, while we are trying to manage the RD, the lens is moving. And in this case, if we do a FGE, the lens will come into the anterior chamber and cause problems later on. So we had to optimize this lens. We have to bury the optics below the anterior capsule, and then proceed for the vitrectomy. So now again, if you have not managed the anterior chamber well, then you see the IOL is now stable even after doing fluid air exchange, and then you do cryo and put in silicone oil in these cases. Now coming to the management of the retained lens matter which is there. So sometimes you will see that the lens matter is there and there is the retinal detachment. The point here I would like to make is, do you have to complete the vitrectomy before you try to attempt the removal of the lens in these cases? Because if you try to remove the lens, you try to cut the lens, or you try to fragment the lens, in the presence of vitreous, the vitreous may get entangled, the retina may be pulled, and you may be causing number of iatrogenic breaks. So first take care of the vitreous, and then you take care of the lens, and then if you have to complete your vitrectomy, complete the vitrectomy and proceed with the management of retinal detachment later on. So here now the lens matter is taken care of, the residual vitreous which is now remaining in the periphery is taken care of, and the fluid air exchange is being done. So in the last, there is management of dislocated IOLs which may be present with the retinal detachment. So this was a patient who had a dislocated 3-piece lens with a retinal detachment, and this 3-piece lens was fixated first. A scleral fixation was done. The flaps were created, and the sclerotomies were done, and the haptics were brought out and buried into the scleral pockets. And once this lens is stabilized, you can in fact, if you have a proper capsule, you can put it on the anterior capsule, and then you proceed with the management of the retinal detachment here. Because the patient had PVR, we did primary ILM peeling also, and then we did a fluid air exchange, and laser and silicone oil is again used in this patient. And this is another IOL. Sometimes this IOLs, you can't be able to fixate them. You see one of the haptic is broken in this IOL. This IOL needs to be removed. So what you can do is you can put PFCL to stabilize the retina, and then make a corneoscleral tunnel, bring out the lens and put in another lens, and then proceed with the cataract surgery. Then proceed with the retinal detachment surgery. So here the lens is being brought up and it is being removed, and another lens is being, because the capsule is adequate, so the lens can be put in the sulcus here. The lens is put, and further the retinal detachment is managed. I'm doing a primary ILM peel in this patient also, and now you see fluid air exchange being done. The break was treated, and oil was used as a uh, tamponade. So I think the time is over. So in conclusion, I'll say there are three types of cataract surgeons. The first is cataract surgeons with good VR knowledge who will do a proper pre-op and intra-op and post-op thing. And the cataract surgeons who know that there is something called retina and posterior segment will have some kind of retina surgeon working with them. And the last one is the phacologist who just aim to put lens and forget about anything else. And this is one example. I just thought that I was doing this I just thought this is a dislocated lens, but you see there was a whole part of the lens as part of the optic and one complete haptic which was missing and which has to be removed. So I hope we don't create such mistakes. Thank you.
Thank you very much. I think we can take some questions, but to begin with, one of the most challenging parts of this surgery is to maintain visualization.
Yeah.
You know, air bubbles can come into the anterior
Yes.
chamber, and I think I noticed you had a few bubbles in one of your
Yes. Yes.
cases. And also the frosting of the intraocular
Intraocular
lens. Do you have
lenses.
any tips for us?
I think the use of viscoelastic is one thing that you should keep in mind. If you have this recurrent problem of the air bubble coming into the anterior chamber, you can use viscoelastic so that the air remains behind. And also if you have frosting behind the lens, again viscoelastic, you can coat the posterior surface of the lens with the viscoelastic, you won't get it. But again, what I'll say is if there is a silicone lens, even if you use the viscoelastic, it won't stay there. So it's better to avoid these type of lenses which are not compatible with retinal surgery.
Any questions from the audience?
Sir, I have one query. Most of the time in these referred cases, the tunnel is pretty bad. They were already put some 3-4 sutures. So the minute you put it, your infusion becomes a washing machine, you know, and the IOL starts floating around and hitting everything. So do you like to make a separate tunnel superiorly, close this properly, or do you just proceed with the same thing, or how do you do that?
I think it is situational, depends upon situation to situation. If you are able to repair the older tunnel which has already been made, I think that will be the best procedure. But if not, if you still think that there is a problem, then you can shift to another tunnel. So I had done one case in which what we did was like there was a clear corneal incision which had been done for cataract surgery, and there was a problem, and we can't do this. We created a scleral corneal tunnel just below that in the different plane, and we did the surgery. So it's I think all situational, depending upon the case.
I think another important thing is that whenever you are having a complication during cataract surgery, it's very important to close all the sections.
Yeah.
Especially when you are anticipating that there is going to be a subsequent VR surgery.
Yeah.
I've often seen the patients being referred where they feel that the side ports really don't need to be, sutured.
Yeah.
But I feel that if you are using a tamponade, you'll be asking the patient to lie prone, And even during the surgery, sometimes you really have to spend time to close those sections before you can go ahead with
Yeah.
the VR surgery.
I think when you are doing these type of cases, the most of the time is spent on optimizing the cataract surgery that has been done earlier.
Exactly.
You spend less time on retinal detachment repair, but mostly on the cataract surgery part.
Once nucleus has dropped or IOL has dropped,
Yes, sir.
do you prefer operating at the same time, means in operation theatre, or you prefer to wait and case to be referred?
So if you have a capable VR surgeon, then do it. If you can do it, it's I think there is no harm in doing it. But the only problem is like nowadays most of the cataract surgery is being done in under topical anesthesia, whereas the vitreous surgery requires a local anesthesia, at least local anesthesia. So if the local anesthesia is possible and you can take up the patient, there is no harm in taking it up the same day. There is no harm. In fact, if you have delayed it, then you have to delay it for some time at least for the anterior segment inflammation to settle down, for the cornea to clear up, and then take up the patient for VR surgery.
And with how much minimum of training you can create a practical retina surgeon capable of removing dropped IOL, dropped nucleus?
Pardon,
Means
sir?
medical colleges mushrooming all over, means every district, one medical college. There is acute shortage of retina surgeons.
Yes, sir. So I think there is no harm. There is no harm in actually if in waiting also, but I won't advise that you should fish out the lens fragments if they have fallen. You try to bring them out on the same day. If you don't have access to a VR surgeon, I think it's best to close the case. Just as Dr. Manisha said, just properly manage the anterior vitreous, put in the lens if it is possible, then seal all the incisions properly, and then send it to a VR surgeon maybe a few days later, rather than fishing out the fragments on your own. That will be catastrophic.
I think just to add to what Dr. Sangeet has said, I think what he was basically meaning that what is the minimum training you need
Yeah,
for
okay.
taking out the nucleus. I think we have to be very clear on this, that there's nothing like that, okay, I'll go in and just take out the nucleus and come out. Either you are a VR surgeon where you are trained for everything, or you're not a VR surgeon. So once you go inside the vitreous cavity, you are not sure whether you land up with other complications like a retinal detachment or a retinal break. So you have to be completely trained. It cannot be a limited training just to be removing the nucleus.
Sir, I noticed you did the ILM peeling in that detached retina patient. So do you advise peeling regularly?
Not regularly, but those cases were PVR cases actually. They already had onset PVR. For PVR, I generally prefer to do a ILM peeling in the primary surgery itself.
Mary, please. Yeah.
Under air or under PFCL?
You can do under PSL, whatever is comfortable to you. In these cases, I didn't use any tamponade. I just peeled.
Thank you.
Thank you.
So
Thanks a lot.
thank you very much. So we'll move on. Can we have the pre-recorded video, please, for Dr. Mary Ho? Yeah, so unfortunately, she cannot get a visa to join this meeting. So we've got a pre-recorded video on surgeries for dislocated IOL. Can we have the audio, please?
Audio.
Quite challenging for us when we are handling with a dislocated lens, because usually the situation is complex. A lot of the time, you may be referred from the colleagues with a complicated cataract surgery, while because of the prolonged operation and manipulation, the cornea may be cloudy. The sutures may be, there may be a lot of the sutures and causing the excessive seal in the cornea that would also impair the surgical view during the posterior segment surgery. And also another scenario would be if patient receive multiple operations such as LD fixation, removal of the silicone oil, and for the period of time this cellular status is being weakened, the patient may have dropped the whole IOL complex. The second scenario would be the presence of vitreous hemorrhage. For example, in a post-SFIOL scenario, while on passing through the sutures may cause bleeding in the ciliary body, and a vitreous hemorrhage would also impair the general view for assessing during the pre-op stages. And in the case of prolonged aphakia, the patient often present with meiosis, and it would be quite challenging for removal of the lens and also for resuturing or re-anchoring of the lens haptic. So in the beginning, we have to assess in what situations, in fact, we are handling with, whether it's a complete drop of the IOL complex or if sonnular support is in fact fair or adequate at one side while the other side was being dropped. So in that juncture, we may have to only replace or resuture at one side of the haptic. The type of the IOL that we are handling with and also the capsular bag status, whether it's a prolonged fibrosed capsular bag and it is very difficult to be separated with the intraocular lens. So these are the common IOLs that we have to bear in mind before handling of the dislocated lens. In the old days, we do a lot of the ECCEs for the dense cataract. The patient tend to be inserted with a PMMA lens. For the PMMA lens without anchor site at the eyelets at the haptic, it would be very difficult for resuturing the PMMA lens back to the sclera. So it is recommended the whole PMMA lens to be removed and reinsertion of a new intraocular lens. If the dropped intraocular lens is a three-piece one with a central acrylic optic and also the PMMA haptic, for example, an AR40E or ZA9003, that would be a good scenario that we can use the same IOL for refixation. For one-piece IOL, generally, we will recommend for removal of the IOL either in a manner by cut and explant or by twist and a removal approach. So we have to use intraocular agents to help us for removal of the lens. And for example, we have to use PFC to flow up the lens to the anterior chamber before we can do further manipulation. So how can we avoid retention of the PFC, especially when you open up the wound, it causes a bit of the turbulence by injection, and it causes a lot of the small globules formation of the PFC. And also, usually for a vitrectomy, we aimed for a complete vitrectomy, but in a situations while the corneal status, the clarity is impaired, it would be very difficult to assess for any cortical features left in the macular region. So very good use of the TPA to remove the cortical part of the vitreous would reduces the chance of ERM formation post-op. Say, for example, this is one of my patients with the IOL dislocation explant and also reimplantation of the flange IOL using the Yamane technique. However, during the operation, after injection of the PFC, and I did not remove the PFC before further manipulation of the Yamane technique flange IOL. And because I opened up the wound wide for the period of time, the infusion cannula kept injecting of the fluid and it makes a lot of the turbulence flow. And despite multiple effort in removal of the PFC globules, there is retained PFC post-op. So during the second operation, how can I make sure that all of the PFC small globules are being removed? I injected the vision blue, and so that the small globules of the PFC stay nothing. In fact, there are multiple globules for complete removal. So there are tips for flanged IOL. So we have to make sure the wound creations, whether or not being 90 degrees apart for the anchor site is a good option. I think a slightly tilted approach would be towards the left-hand side would be a good approach because the trailing haptic would be the one which is difficult to be threaded. So do we need to thread out one side of the haptic first before handling the other side? And because when you lifted one side first, the IOL centration is tilted towards the side being threaded out, and it would make the rest of the handling very difficult. And also, during handling of the needle baffles, if you put the baffles towards your side or make it the physiological position for threading of the haptics, it would be easier for the haptics to be stuck inside the baffle. So what are the causes for IOL decentration in a French technique situation? So this is a study published in Retinal recently. So first of all, we have to make sure that the anchor sites are 180 degrees apart, because if there is any tilting, that would cause a significant increase in the cylinder. For example, 10-degree tilting would cause at least 0.5 or 1 diopter increase in the cylinder. We have to make sure that both sides of the tunnels are of equal length. So usually we will mark the site of entry of the needles and also the site of exit of the needles to be 2 mm apart, so that if one side is longer and the other side is shorter, the IOL tends to kink towards the side with a longer tunnel because the force there is stronger, and it also causes decentration and also tilting. And with the shorter tunnel side, there would be a tendency for vertical tilting of the IOL, so it in fact would affect the overall optical outcome. So I do have a few cases to share. So this is a patient with the inferior RD silicone oil removal that I mentioned early on with retention of the PFC. He developed the inferior optic capture after the flanged IOL, after removal of the originally dislocated lens. So after learning this, I think in the future I would recommend for cases that you would afraid that there would be risk of the IOL capture, performing a peripheral iridectomy would be a good option for prevention. And this is another patient with a history of, it's an only eye patient. He's a 73-year-old patient with a history of white dye retinal detachment, and this is the white dye is being the only eye. For the left eye, the patient has already undergone hypotenuse changes because of multiple RD failed fixation. So for the right eye, the whole IOL complex being dislocated, so I end up performing the scleral tunnel wound for this patient for removal of the IOL complex and insertion of a PMMA, scleral fixated 4-point fixation by 10-0 Prolene approach. However, postoperatively, patient developed persistent hypotony, hyphema, vitreous hemorrhage, and choroidal detachment. Given this is the only eye of the patient, I went in a few times for injection of the anterior chamber, suturing all the wounds, but still the IOP is not coming up. And in the end, we performed UBM in this patient and find out that there may be a small iris root or ciliary body cleft causing the excessive drainage, because when I created the scleral tunnel wound in this eyeball with 25 millimeters long, maybe there is trauma to the ciliary body or iris root. So the corneal colleagues help us to put in SF6 gas injection into the anterior chamber, and eventually the eye's pressure builds up gradually. And now, currently, the visual acuity is 20/40. So another patient who received cataract surgery many years ago with a one-piece PMMA lens, because the PMMA lens was not good for refixation itself, we intended to do explantation of the lens. However, we use not a very good technique. We use scissors to try and cut the PMMA lens so that we can not reduce the risk for creating a large wound for the patient. But then because when you cut it, it's really hard. It breaks inside the eye like an explosion and causes a scratch at the endothelium and causes a DMD. So then eventually we have to put in the SF6 for reposition of the DMD. And now currently the patient is doing good. So in conclusion, the surgical management for dislocated intraocular lens can be very challenging. And I have to admit that a lot of the time I learn through the mistakes or from the patients or by handling with the complications by arising from the inappropriate pre-op planning. So I hope you can understand more by this sharing, and thank you very much.
That's great. So yeah, because Mary is not here physically, so and she can't join online as well. So we'll proceed with the next talk. So next talk will be by my co-chair, Professor Andrew Chang, and he's going to talk about endophthalmitis vitrectomy, and he's going to also show a video, a case, right?
Yeah, that's right. So if you can bring up my first talk, Mary talked about learning from your mistakes, and this happened to me last week. So I had the video made up quickly so I can show you what happened and what we did to get out of it. We are seeing more and more, and I think you've noticed this, more and more dislocated lenses. And furthermore, our anterior segment colleagues are trying to manage these more and more using Yamane style or like a cow hitch to try to hold it. And what we're finding is that these eyes have had capsular tension rings, and so the whole complex falls backwards. But this is a case that I managed last week, and the title says subluxed IOL and sutured IOL and sutured again, and I think you probably can guess what happened here. So the case begins, he's had multiple surgeries, and the plan was to do a 4-point fixation Gore-Tex sutured IOL. Here was setting everything up. We're using 25 gauge, but I know that ultimately we'll be moving to 27 gauge. This is a plate lens that has fallen in the back of the eye, and we then were able to retrieve this. There's really no point here in fixating this lens, so it's explanted. We are now using an IOL that has 4-point fixation. Gore-Tex is used, and because of the 4-point fixation, we find we've got greater stability. Here it's been put in, and I'm just now tying up the Gore-Tex. We've closed the wound, and then this happens to me. Oh, the Gore-Tex suture breaks, and the whole lens is now tilted back into the eye. You can see how it looks now. So we then started threading another Gore-Tex whilst the lens is inside the eye, and we were able to retrieve this situation. So the options would have been to take the whole lens back out again, but this does happen. And why does it happen? Well, I think that as we're using here max grip forceps in order to pick up the lens, and as we use it more and more, we must remember that they are disposable, and so the tips get caught. So as I was burying the Gore-Tex suture at the end, it probably didn't let go. And as I moved up, it actually unraveled Gore-Tex, because Gore-Tex can't be broken, but I've clearly unraveled the suture. So we might talk a bit more later about techniques that we are using and what's available for us now and for anterior segment colleagues to deal with. We've talked about drop nuclei and other situation. Can I have my next slide? Oh, thank you very much. So this is absolutely devastating, and we are seeing this not only following cataract surgery or other intraocular surgeries, but also increasingly with intravitreal injections. And I know in India you have an entirely different spectrum, but this is an Australian perspective. These are my disclosures. So the title of this symposium was Dealing with Complications Following Ocular Surgery. Well, this is the one that we fear most. And these are the 5 cardinal signs of infection. And it's important to remember this because sometimes you will see other diagnoses like a TAS or uveitis or retained lens matter. And so we'll be faced with a case where we'd be worried that there's an endophthalmitis and what to do. And I think what we do in most cases, we treat as for an endophthalmitis, because it's devastating if we do not give antibiotics. So unfortunately, this is a patient who developed endophthalmitis, and it was actually his only eye. And we were not able to save the eye despite surgery, and then our oculoplastics specialist ended up removing the eye. So who gets endophthalmitis? Well, it's fortunately very rare, but there are patient-related factors, and that previous patient had very, very disorganized eyelids and scarred conjunctiva. There's procedure-related factors such as clear corneal surgery, or when there are complications such as unplanned anterior vitrectomy. And surgeon-related factors you would think would be a factor, but trainee and increased time was not shown to be a factor in several studies. So we are now seeing, at least in Australia, a changing spectrum of endophthalmitis with increasing intravitreal injections. We are seeing a different type of bacterial organism. And we wanted to ask whether the outcomes of endophthalmitis following cataract surgery differs from intravitreal injections. And so here we present 100 eyes in 100 patients in two groups, 53 following IVI and 48 following cataract surgery. And the take-home message when we looked at the patients presenting to the eye hospital was there was a significantly increased chance of a streptococcus infection, much more common following IVI, and it was thought to be due to aerosolation of saliva, that is, not wearing masks whilst doing injections. And if you did get a streptococcus germ in the eye, you had a very poor visual prognosis, and your chance of an enucleation or removal of the eye was 17 times greater. So we have data, the endophthalmitis vitrectomy study, which guides us into how we treat endophthalmitis. But things have moved on. Technology is different, antibiotics are different. And I think in this country and in our region as well as in Australia, there is a trend towards earlier vitrectomy. And in theory, it allows debridement of bacteria and inflammatory debris, better diffusion of antibiotics, and in theory, more rapid visual recovery. So these are the technological changes, and if you go into the trade display, you will see that we've got 27 gauge, Dr. Mittal was doing 27 gauge, we've got better cutters, we've got better illumination and vision systems. Also our anesthesias are changing, and access to care is much different now. When the EVS was done, it was probably harder to get into an operating room, but in this case now, I know our colleagues in the US and in Japan, they can get into the operating room very quickly because it's emergent. So these are the potential advantages, and these are, I think, quite intuitive, but there are challenges which include poor visualization, damaging the retina, accessing an operating room as well as anesthesia. So this is another study that we performed at the eye hospital in which we took patients to an operating room for vitrectomy surgery early. And the purpose of this study was to evaluate the efficacy but also safety of early vitrectomy in acute endophthalmitis. So here we looked at 64 consecutive patients during this time period, and at 12 months we examined the primary outcome, what their vision was, and whether there were any other adverse events or prognostic factors. So this is what we do currently. Immediately the patient is taken into the ED or procedure room to perform a tap and inject. This is done with local anesthesia. A 23 gauge needle is injected through the pars plana. 0.2 of a mil is taken out. Often this may be difficult, but that is the aim. And vancomycin and ceftazidime are given straight away, even if a theatre case is booked for several hours later. And then we aim to perform vitrectomy surgery as soon as it is possible, in this study within 72 hours. And visualization is an issue, so the corneal epithelium sometimes needs to be debrided. We need to wash out the fibrin and the hypopyon from the anterior chamber. The aim is to do a core vitrectomy, and we look for any tears that we might have caused, and this is treated. And we can talk later about whether to use gas or oil tamponade, and there is increasing evidence that oil tamponade may in fact be more effective in terms of antimicrobial effect. So here are the 64 eyes and the baseline characteristics, and you can see here that the mean time from onset of symptoms to a vitrectomy was 0.8 days. So they got into the operating room quickly. And if you look at the 64 eyes, they were mostly due to phaco or post-phaco as well as post-IVI. And if we looked at the bacteria in this study, most were still Staph epidermis, followed by Streptococcus and also Staph aureus. And these are the visual outcomes. So overall, the vision improved after they underwent a vitrectomy procedure, with 89% improving sight and 42% ending up with 6/18 or better vision. And when we looked at the patients who did better, the ones that were post-cataract did better, as well as those who were culture negative versus culture positive endophthalmitis. But there were complications, and this is what I'd like to talk about now. So about 10% of our eyes developed a retinal detachment, but there were other complications such as epiretinal membrane and hypotony, and in our series we lost 2 eyes. So I'll take you now through some cases. This is a patient who developed endophthalmitis following IVI, and it was pretty fulminant. You can see quite a purulent vitreous. There's material on the retina itself. It certainly does not look good. Sometimes the material that you see there could be the antibiotics that are often given straight away. Unfortunately, this patient about 2 weeks later developed a retinal detachment. So she did well after the vitrectomy, but you can see here there is early PVR. And in these cases, the retina was repositioned, and we used silicone oil tamponade once we treated the areas where the retina was necrotic. This is a patient who developed a Haemophilus infection, and we really thought that this eye was going to be lost. Again, very purulent vitreous. The consideration here is how aggressive are we in shaving the vitreous, and do we create a PVD? And in general, we are not aggressive in creating a posterior vitreous detachment, as you can create breaks. And we remove the vitreous as safely as we can, but the worst thing for us in this situation is to create a break. This patient did actually very well, but about 3 months later, you will see that she loses vision due to an epiretinal membrane, and this can occur following endophthalmitis. Here, the epiretinal membrane is causing quite marked distortion and traction to the neural macula with a fold. but the membrane was able to be removed subsequently. This patient developed choroidal effusions, and this is one of the other things that ultimately causes loss of the eye in the longer term. Here there are large choroids on the temporal side. We're using the trocar system to try to evacuate the suprachoroidal fluid. We remove some of it, and the rest comes out once we actually remove the cannula. And here then the choroid is reattached, and we go on to perform a air tamponade. So in conclusion, what we found is micro-incisional modern vitrectomy techniques are effective in improving sight. We are considering, as many of us, whether the EVS is appropriate. We still do not have a randomized control study for modern management of endophthalmitis, but in particular post-IVI endophthalmitis. There are colleagues in the US and in Japan who are collecting data to look at retrospective data. There are a number of techniques for clearing the view, which makes the vitrectomy safer. The questions remain is how aggressive are we in performing the vitrectomy? How aggressive are we in creating a PVD? And the choice of tamponade. A number of our colleagues routinely just put oil into the eye and find the eyes do settle, but subsequently the oil needs to be removed. So whilst we can perform vitrectomy surgery, we also need to deal with the complications, and these are often significant and may be blinding. Thank you.
Thank you very much, Andrew. Any question from the floor? Would you inject any intravitreal antibiotics after putting gas or oil?
Yeah. There are, in theory, algorithms to halve the concentration, and we do that. We just give about half of it if there's a partial airfill or complete airfill.
I had one question, Dr. Andrew.
Yes.
If you're not having a retinal detachment on the table, would you still go ahead and put silicone oil?
I don't.
You don't?
No, I don't. But a number of my colleagues have looked
Yeah.
at the organism and the antibiotic distribution, and they actually feel that oil tamponade will concentrate the antibiotics next to the retinal space. Yeah.
And also, I think there was a paper published which said that silicone oil per se has some antimicrobial
Yes.
activity.
That's right. And
Yeah.
I think if you ask older colleagues around the time of the EVS, that was their general impression, that it was fantastic at controlling the distribution of the inflammatory mediators as well.
One question, what are your tips for fungal endophthalmitis? Sometimes you find that even after vitrectomy, forms membranes behind the iris and keeps popping out of the pupil. So it's very resistant, you know. Do you like to inject very often, and how do you give them good outcomes for fungal?
Well, this is what you're really seeing here in India. You see a lot more fungal endophthalmitis than we do in other areas of the world. I think that when we have cases of endophthalmitis, we are aggressive with early vitrectomy, and you may need to, as you've just indicated, continue to give antibiotics, but often you may need to go again to remove cyclitic membranes and inflammatory membranes. These are really challenging cases.
I think just to add to that, like fungal infection, as Dr. Andrew mentioned, they are very difficult to treat. There are a few things to remember that you have to be very aggressive. Like IOL has to really be sacrificed, at the first go of the vitrectomy. And also the fungal granulomas, they tend to, grow behind the iris because that's a dark, cool area. So that's where they keep fulminating. So I've myself treated a very bad fungal end-off. Sometimes we also have to opt for cryo and you have to actually do a cryo to the entire fungal granuloma. Oil is a good option in these cases. I think you have to be again more aggressive in putting in silicone oil in these cases. And lastly, when you're treating them with antifungal intravitreal injections, I think you have to be giving them at least once every 24 hours. So don't wait for 48 hours or 72 hours to repeat the injection, and especially when you vitrectomize the eye, I think the intravitreal has to be given every day.
So what I have realized is there are two types of managements in endophthalmitis. So one is in the acute phase of the endophthalmitis, and one is in which the eye is now quietened down and they're just doing vitrectomy for media opacities or the residual exudates. And I think in those cases which are chronic, which have become chronic, and just doing a vitrectomy and no oil or no gas may do. But in acute phase, so there's no middle approach. Either you just do a core vitrectomy and put in intravitreal antibiotics, or you have to go all out. You have to induce the PVT, you have to put in oil and give intravitreal antibiotics. Otherwise, the problems of retinal detachment and necrosis, they keep on occurring post-vitrectomy surgery. What is your take?
No, that's a very, very good point. So if we're in the acute setting and the visualization is difficult, then often in the acute setting, there may not be a PVD. If you're lucky, there's a PVD already because the patient's older anyway after IVI. But say it's a diabetic patient or somebody young, it can be very hard to separate the vitreous. I don't aggressively chase it, but if it comes, then that's very good. I'm like you. I think you should try and clear it as much as possible. But in our studies and guidelines, and what we tell the fellows is the core vitrectomy is not really just a core. It's actually as much vitreous that we are able to remove what we believe safely within the limits of what we can see. And I completely agree that there's a second phase. Yeah. And the second phase is epiretinal membrane vitreous opacity. In the context of IVI, this does raise a consideration regarding the half-life of IVI injections. That is, whether the drug is still durable. And so that's a consideration, as well as the fact that whether you would go in again and continue IVIs, because patients often won't agree to that.
Thank you.
Do you prefer sending PCR for fungal and bacteria panel in each and every case, because most of the times the culture and gram stain, most of the time it comes inconclusive and you're really confused. So do you advise doing it in all the cases? Get a better idea.
Oh, well, in our series, 2/3 were culture negative. So completely agree. I think if we have now techniques to identify the germ, then you know where you are. And fungal is hard to diagnose. You really need to get the specimen across, and a really good microbiology department.
Okay, thank you. So it's time to move on. So the next talk will be by my other co-chair, Dr. Manisha Agrawal, and she's going to talk about another very devastating complication, which is suprachoroidal hemorrhage.
A very good evening to all of you. Second one. So, can I have the sound, please? So this is a patient undergoing penetrating keratoplasty, and you find that the surgeon has taken out the nucleus, the posterior lens capsule is intact, and now the IOL implantation is being tried. The problem is the PC initially was intact, but now it's given way, and now an anterior vitrectomy is being done. So you see a lot of time is being wasted. Now, you can see a whitish reflex at the back, and that is a cause of worry. And actually, a surgeon has to recognize that sign and be very careful not to be wasting any time. But here you see a lot of time was actually wasted, and then suddenly when the reflex starts changing, a panic button is stuck, and now the surgeon is really speeding up, trying to put the corneal button in place, but the battle is already lost, where you have all the intraocular contents just coming out and you're not having any time to actually salvage the eye or to suture the corneal button in place. So we have to be very careful of recognizing these very early subtle signs where things are not really working in the right direction, and you have to close the globe as early as possible without really thinking of implanting the IOL or doing other things. And the prime concern should be just to be closing the eye. So here you see there is a whole lot of bleeding now, and the battle is lost. So we really don't want this situation to occur, and you have to be very careful. So the course of action during and after a suprachoroidal hemorrhage is that you have to stop immediately once you notice something is going wrong, and even a moment's delay can actually cause a havoc, and you are not able to really salvage the eye. So the prime concern, as I mentioned, you have to seal all the incisions at once. And if you can increase the intraocular pressure once you have closed the eye, please do it as early as possible, avoiding further hypotony and further bleed from the choroid. After the suprachoroidal hemorrhage has occurred, you of course have to medically manage the patient. You have to control the intraocular pressure because there is so much of a volume increase inside the eye. You have to also control the inflammation, and then subsequently keep doing serial ultrasounds to see if there is any evidence of hemolysis of the blood in the suprachoroidal space. And like you see over here, the scan, what I have put, you see these echolucent spaces which are suggestive of the hemolysis. Don't be in a hurry to manage the suprachoroidal hemorrhage, because you would not be able to do a complete drainage of the suprachoroidal hemorrhage if you've intervened too early. So give adequate time. What I would prefer is to wait at least 3 weeks for the blood to liquefy and then to intervene so that I get a more complete drainage of the suprachoroidal blood. So the situation after expulsive hemorrhage is that the primary surgeon has actually surrendered. For him, the battle is already lost. Some bold decisions have to be made because you have to decide when to intervene, what to do. And it is actually a true war against blindness. So these are certain things which really intrigues you, and you have to really decide when to intervene and how to intervene in these eyes. So this is a small video of draining of the suprachoroidal hemorrhage. So an AC maintainer is put. A scleral cut down is made over here. And you see cyclodialysis spatula is used to drain the suprachoroidal blood. Oh, it's coming. So you have to see where is the maximum height of the suprachoroidal or the choroidal detachment on ultrasound, and that is the quadrant that you're going to target for draining the suprachoroidal bleed. AC maintainer is very important because you want to simultaneously maintain the intraocular pressure once the blood is being drained out. After you've done that, you can place a 6 mm infusion cannula. It's important to check the infusion cannula tip inside the vitreous cavity. If you're not sure, please do not switch on the infusion cannula and continue doing your work with the AC maintainer. It's important to put in your trocar cannula straight and not beveled. And like Dr. Andrew just showed, whatever residual bleed you have can be actually drained by partially inserting the cannulas. Now you can just go in and clear the anterior chamber, clear all the blood clots inside the anterior chamber so that you get a much better view to continue your posterior segment surgery. So here you already have a lot of retinoretinal adhesions which have occurred secondary to the suprachoroidal hemorrhage. So you have to be very patient in separating out these retinoretinal adhesions. You've placed a small amount of PFCL to protect the posterior pole. And gradually you peel all the membranes, opening up the retina. Now it looks much better where you can appreciate the posterior pole. You sometimes have to resort to making a relaxing retinotomy to clear out these huge blood clots under the retina. And gradually you have to keep injecting the PFCL till the whole retina settles down. And subsequently you do a laser photocoagulation to reattach the retina after fluid air exchange. You may be left with some amount of a choroidal bulge, which can be just left alone as it gradually settles down, and after this you can do a PFCL silicone oil exchange. So this patient apparently was a one-eyed patient, and we have a 6 months follow-up of this patient where he did get back a vision of 660 and he was ambulatory after having undergone this disastrous complication subsequent to a penetrating keratoplasty. So thank you so much for your patient listening.
Thank you. Very challenging indeed. So do you usually wait a little while for the blood to hemolyze before you do the surgery? How long do you wait?
I usually prefer 3 weeks, 2 to 3 weeks, but I surely don't intervene before 2 weeks.
Yeah. Question?
Yep.
Some surgeons have tried using TPA in multiple quadrants in suprachoroidal space so that they can operate early. What is your...
I've heard of that technique where they've used TPA for an early hemolysis of the blood, but I still don't have any personal experience of using that technique.
Manisha, what's your first indication that something's going wrong?
First indication?
Yeah, the first indication, like you know, in cataract surgery, you've got an open sky
Right.
PK, but just say in cataract surgery, or in the old days in which we used to do extra cap, you sense something's going wrong. So what's your first indication? You said you don't want to be mucking around.
Right.
Yeah.
I think the first would be where you are having an undue upthrust. You're trying to put in the IOL, it's getting pushed out. You are having a slight change of the reflex that you're seeing at the back. I think that is something to be really recognized. And I think when you're having anything like this, I think the challenge is that don't persist with what you're trying to do and just close the eye.
I think one thing is like the glow that you are seeing, is there will be a slight eclipse on one side. I think that is the first thing you come to notice, that the glow is slightly reducing from one side. And that is the point you have to stop.
Yeah.
Because I remember one case I was discussing with her earlier also. I had just completed everything, only the IOL has to be inserted. I saw the glow diminishing, but I thought like only it is just going to take few seconds to put in the IOL, and then I'll just close it and finish it off. But the suprachoroidal hemorrhage does not give you that much time also. It was so devastating, it just came out. So I was not able to put the IOL. The IOL also came out, everything came out. So you have to stop there only. That is, I think, the best message for the cataract surgeon once they see that.
So Sangeet, is this modern sutureless surgery where you had that case?
Yes, sir. I think that the incidence is now much less when we're doing a closed chamber surgery. But still, we do have seen happening these kind of things even after closed chamber surgery.
I think where we go wrong is where we try to persist with what we are trying to do. You know, if we have set our goal that we have to put in the IOL, we just tend to ignore the subtle signs and continue putting in. And the eye is telling you that something is going wrong. So I think it's best to just close the eye at that time and secure the section so that the things don't come out. Thank you.
Thank you. So last but not least, we have Dr. Maria Jung-Loy, and she's going to talk about management of malignant glaucoma.
Good afternoon, everyone. I'd like to thank APVRS for allowing me to speak this afternoon. So I'm tasked to talk about, this is not my, no, not that one, malignant glaucoma. I'm tasked to talk about management of malignant glaucoma. Okay, so malignant glaucoma has been called several names, including aqueous misdirection, ciliary body block, among others. It is due to an abnormal relationship between the ciliary body, the lens, and the anterior vitreous. So the exact mechanism is still unclear, but it can be multifactorial. So one theory is that the misdirected aqueous behind the anterior hyaloid, lens, and the zonules, they are unable to reach the anterior chamber, causing an increase in the volume and pressure behind the lens, pushing forward the lens, the iris diaphragm, and the ciliary body, causing a pupillary block and increase in pressure in most cases. So it occurs in around 2% of glaucoma surgeries. Risk factors include short axial length, shallow anterior chamber. Both are characteristics of female eyes, no? And it is also increased in patients with aqueous misdirection in the other eye. Reports of malignant glaucoma after laser iridotomy, cataract surgery, and even the use of myotic drops because of the relaxation of the zonules, then this anterior displacement of the lens. So symptoms in early signs, no? Patient may have a myopic shift, no? They can read better at near because of the anterior displacement of the lens. Patient may have blurred vision, eye redness, and eye pain. Signs include shallow or flat anterior chamber because of the anterior displacement of the lens iris diaphragm and the anterior hyaloid face. They may have elevated IOP, but they may also have normal eye pressure, especially in patients post-glaucoma surgery. In making a diagnosis of malignant glaucoma, it is important to consider angle closure from pupillary block, especially in patients with flat or shallow anterior chamber and elevated IOP. No? But unlike your malignant glaucoma, wherein you have a flat anterior chamber uniformly, including the central part, with your pupillary block, most of the time there's iris bombay, flat or shallow peripheral anterior chamber, but reasonably there's a space, no, centrally. So what you can do, what can differentiate the two is your peripheral iridotomy or iridectomy. So if you have a patent peripheral iridotomy or iridectomy, but still with very flat chamber, most likely it's malignant glaucoma. Your diagnostic imaging plays very important role. In patients with very hazy media, you can do ultrasound to rule out other causes of flat or shallow chamber like your choroidal detachment. Your ultrasound biomicroscopy or anterior segment OCT will be very helpful in assessing the orientation of your angle, the iris, and the lens, and the ciliary body. So management involves a multifaceted approach. In patients post-ocular surgery, you need to consider check for wound leaks, and then in patients post-glaucoma surgery, you need to also check for overfiltration. If you have a flat chamber and then you did already a laser iridotomy, it's still flat. If in doubt about the patency of the iridotomy, you can do another iridotomy just to be sure. Once it's established that your patient has malignant glaucoma, medical management can be started. Okay, so the treatment focuses on eliminating pressure differences within the eye, aiming to reduce the aqueous humor production, shrink your vitreous, and then improve the aqueous flow inside the eye. So while 50% of cases respond to medical therapy, there's a high chance of recurrence. No? So your laser treatment aims to release the aqueous trap behind your anterior hyaloid. So sometimes even with your medical therapy and laser therapy, recurrence rates, they're high. That's why surgical treatment may still be needed. So for the surgical management, the aim is to restore communication between the anterior and the posterior segment. So techniques like anterior vitrectomy combined with iridectomy, zonulectomy, and hyaloidectomy, it's an option. But studies have shown that if you do complete pars plana vitrectomy, iridectomy, zonulectomy, hyaloidectomy, and capsulectomy, they give the best results. So don't forget to manage also the contralateral eye. So prophylactic measures should also be done in managing the other eye as well. So sharing with you some cases, okay, from my glaucoma colleagues. Okay, so this is a case of a patient post-trabeculectomy with patent peripheral iridectomy. A few days after the malignant glaucoma event, the chamber was formed, status post vitreous tap and air bubble injection. So this is a case presented by my colleague who's also here, Dr. Tumbokan. He presented this case in APGC in 2021. I co-managed this case with him. This is a case managed with irido, zonulo, hyaloido, capsulectomy, and vitrectomy through anterior approach. So it's an option especially by anterior segment surgeons because they say direct visualization of your instruments, it's better compared to the blind approach via the pars plana. So patient is a 65-year-old male post-cataract surgery who had malignant glaucoma treated medically, combined with laser iridotomy, capsulotomy, hyaloidotomy. But in spite of all those treatment modalities, the vision remained light perception and the IOP remained high. The anterior chamber was flat with posterior synechia. On UBM, the ciliary body was anteriorly rotated with a displaced PCIOL and iris diaphragm. The ultrasound was unremarkable, so there were no signs of choroidal detachment. So we did a stab incision through the cornea, iris, lens, capsule peripheral to the PCIOL, and then up to the anterior hyaloid face. Egress of fluid was noted, and then the eye softened after the escape of fluid through the opening. And then a vitrectomy probe was used to, So viscoelastic was used. After we softened the eye, there was a permanent corneal iris adhesion. So we used viscoelastic to break that adhesion. Sorry, the video's not working, I think. Hold on. Okay, so we injected viscoelastic to reform the anterior chamber. We injected also into the area of the angles to attempt to reopen them. And then we used the vitrectomy probe to remove the membrane and to open up the synechia. And then we also used the vitrector to enlarge the pupil. After that, the vitrectomy probe was used for peripheral iridectomy, zonulectomy, and then additional pupilloplasty. We used the infusion cannula as the anterior chamber maintainer. And then the vitrectomy probe was further used for zonulectomy, capsulectomy, and then anterior vitrectomy. So because of the presence of 360-degree peripheral synechiae, AMED valve was placed. So the vision of the patient improved to 20/50 with good IOP control. So this is another case of malignant glaucoma status post-AMED valve implantation managed with complete pars plana vitrectomy and then capsulectomy, iridectomy, and zonulectomy. So in summary, malignant glaucoma is a serious condition that can lead to irreversible vision loss if not managed promptly. While medical and laser treatments can be effective, they may only provide temporary relief. Complete pars plana vitrectomy combined with iridozonulocapsulectomy appears to yield the best long-term results. Thank you so much and hope to see everyone in Manila for APVRS 2025 this coming December 12 to 14. Thank you.
Thank you very much. Any question from the floor?
I wanted to ask Manisha ma'am, how do you decide where you will do scleral cut down by B-scan guided?
Could you repeat your question, please?
Ma'am, how do you decide where you will do scleral cut down for draining the suprachoroidal?
So as I mentioned, when you're doing the ultrasound, wherever you are having the maximum amount of bulge, the maximum height of the choroid, I think I would choose that particular quadrant to do the scleral cut down.
And also, Sangeet sir, so your technique of putting the haptics during SFI in the Geber-Scheret tunnel using the cut needle, can you elaborate?
Sorry. So what we have seen is like when we make a pocket with the needle and we try to insert the haptics inside the pockets, the haptics generally get damaged sometimes and the whole thing is lost. So what I do is like I break the 26 gauge needle from the middle and I just insert the middle instead of making a pocket. And I just put the haptic into the lumen of the needle and bring the needle out from the other side. The haptic remains in place while the needle comes out. So that gives you a snugly fit haptic inside the sclera. That is, no, it was the same 26 gauge needle. So one point I'd like to make here about this was like, earlier I used to do a partial vitrectomy with removal of the capsule and for these malignant glaucoma cases. But the rate of recurrence or the rate of failure was quite high. So then I switched to complete vitrectomy. And I think I found a very good alternative to this. So if we are planning to do a vitrectomy, then I don't think there's any rule we should stop at just a partial vitrectomy. Just do a complete vitrectomy and get a better results rather than. So what is your view on that?
I agree, but sometimes because of the elevated pressure, you have very poor visualization of the posterior segment. That is why sometimes you're forced to do anterior vitrectomy via the anterior approach. But based on studies, it's best to do complete PPV.
And another thing that you also mentioned was the formation of the anterior chamber is also very important during that part, because if you let it remain so, the things won't get better. Thank you.
I've got a question regarding the timing of going in. Often a surgeon will be asked to become involved. What do you tell our glaucoma colleagues about when a VR consultation should take place?
Okay, I think the sooner you intervene, the better, especially if the eye pressure cannot be managed medically, even with maximum medications. To avoid, if you wait longer, you'll have the other complications like corneal problems, and then you'll have your permanent adhesions.
I found that sometimes the glaucoma colleagues will wait a little bit because it seems to get a little bit better, then a little bit worse, and a little bit better, a little bit worse. And this goes on for about 10 days. And then on Friday afternoon, you're called.
Yeah, or just right before you're leaving for a convention or a vacation.
It's just like when you are about to be doing something on the macula, that's the time patient decides to move.
Yes.
I've never been able to really find a very good answer to that. Dr. Andrea, I wanted to ask you one thing, that have you changed your first line of antibiotics over the years because of antibiotic resistance?
That's a very good point. We haven't changed our intravitreal choice of drugs, so it's still ceftazidime and vancomycin. But we have evolved in our topical drops, but not intravitreal. We don't have any strong evidence at this stage. But in the treatment of endophthalmitis, I think it was mentioned by you that microbiologic diagnosis is really what we need. We can go in and do empirical treatment, but once we have a diagnosis and we know our resistance and whether we're dealing with a fungus or some other unusual bacteria, I think then we can potentially win the war, as you used.
Regarding malignant glaucoma, I am a glaucoma expert. So normally what we do is we take a vitreous cutter and go from the anterior side through the PI. You cut the iris, or if there is a PI, you do the get through that PI, cut the hyalidocapsular adhesions. Until unless you cut that hyalidocapsular adhesion, there won't be any single chamber, and that aqueous which is there in the pocket, it will be released. So rather than doing a whole sort of a big vitrectomy, it is better you do the hyalidocapsular adhesion which are there and release it and make a single chamber between the anterior and the posterior.
Can I just ask, that procedure that you just mentioned, is that done, can you do that in the office or on as an outpatient, or do you take the patient to an operating room?
No, it has to be in the theater with all the precautions. But only thing is, like, you have to go from the anterior rather than doing a posterior vitrectomy. And being an anterior segment surgeon or glaucoma surgeon, you don't require a vitreous surgeon to do it at the posterior segment surgeon. So you go through that PI. If it is not working, it will start working. And if there is not in the zone where you are comfortable doing the further vitrectomy and release, you can create one more hole in the iris and go through that.
Yes. Okay, very good.
Thank you.
So I had one comment regarding the usage of intravitreal antibiotics. The usage of piperacillin tazobactam here is quite, I have seen good efficacy as a broad spectrum. And one question to Manisha ma'am was regarding mention of being aggressive in fungal end-off and injecting every 24 hours. So what about the use of systemic antifungals? Do you advocate equally aggressively, or what would you suggest?
So, if I could hear it properly, you've shifted to piperacillin and tazobactam as the first line, right?
That was, yes, for bacterial, in addition to vancomycin also. So that was just
Right. That's exactly what I was asking, Dr. Andrew, that have they also changed the antibiotics? But I think, as you rightly mentioned, of course, the choice of antibiotics would depend upon your microbiome report, and that is going to be the best guide of what antibiotics to use. Empirically, initially, when you are taking up the patient, when you don't have any report in the hand, yes, we all give some antibiotic empirically at that time.
And in fungal cases, would you advise systemic antifungals?
Yes, of course. Yes. So we have to get a kidney function test done and a liver function as well. And yes, then you have to keep them on quite a long-term systemic antifungals.
So in acute infectious like bacterial endophthalmitis, any role of systemic antibiotics, or all of you still give systemic antibiotics?
The role of systemic antibiotics for endophthalmitis.
Sorry, I don't think we have any established evidence for systemic antibiotics, but we still give, oral anyway, but we don't have that at this stage.
So what's your antibiotic of choice? What you give? And what Manisha ma'am give?
Usually I would use ciprofloxacin. Yeah.
Yeah, we all do that.
Oral?
Yeah, quinolones, they have the best, especially the third generation, they have the best intraocular concentration. So that's what we give, because it's very devastating to have endophthalmitis, so it's better than not giving it. Of course, some people may argue about that.
Thank you.
When you take the sample to send it to microbiology, do you like to, a lot of people say before you switch on the infusion, you try to do a dry vitrectomy and send that undiluted sample, more chances of getting an organism instead of switch on the infusion and you get a diluted sample. Any experience on that, sir?
Usually we try and give two samples. We give an undiluted sample, and we can take that directly. And also we can do an anterior chamber tap as well. And I think increasingly, when you are not certain of the diagnosis, you can actually give the washings. But we generally do not do that, just an undiluted, maybe 1 ml.
Also, when we are trying to collect the undiluted sample, if you start having a hypotony, it's a good idea sometimes you can connect your infusion with air. And that's not going to dilute the sample, and you can collect an undiluted sample. I think we've had a very interesting session with a lot of interaction, questions, and I think it was a nice session. So thank you so much for joining us for this wonderful session. And I also thank my co-chairs, Dr. Andrew and Dr. Timothy. Thank you so much. I'll just request all the speakers to come for a group photograph.